Okay, so we've gone through 2 of these subtypes of depression. The third one that I wanted to talk about is postpartum major depression. Postpartum, this is a funny story. I hope the guy that said this won't watch this tape. And he's not here tonight, so it's good. But I was mentioning to somebody I was going to talk about postpartum depression tonight, and he says, "You know, I had that one time." And I said, "Well, I'm pretty sure you didn't have that. I could be wrong, but I'm pretty sure you didn't." And he was really thinking of a different disorder, but I think he got his disorders confused. So, yeah, obviously postpartum depression means that and I'll give you, and we'll do a case here in a second, but it means that it has to be a woman, because it's somebody who's delivered a baby and gets depressed within 4 weeks of delivering that baby. So most of the time, men, for all you men out there watching the tape or whatever, you're not going to be eligible for this one. So just listen for your spouse's sake. Let's put it that way. So let me give you an example, or a case example of postpartum depression. This one is a young female who delivers her first child without complications and is in tears almost immediately. She had no prior depression or a history of depression. So in other words, while she was pregnant, there wasn't any depression that the doctors knew about or that she could tell. And she'd not had a history of being depressed before. But this was her first child, remember, okay? So she's not interested in the infant now, and she doesn't really want to eat. She's not sleeping well, and she starts to become, interestingly, I think, did I say earlier about psychosis, that losing sleep is really a big risk factor for psychosis. So if you, really any of us in this room, if you told us, if you made us, forced us not to sleep, there'd be some point where we'd get psychotic, all of us, even if you don't have a history of that before. We'd all be susceptible to that. So losing sleep is kind of a key, and also you should remember that when it comes to treating these things, because that's the first thing you got to do to help with psychosis, is get the person a good night's sleep. So this woman, she starts not sleeping well, and she becomes obsessed that her child is possessed by the devil. I don't know why I got such a religious theme here tonight. I guess because a lot of times psychosis does have a religious theme. For some reason, I don't know why that is, but there's a lot of religiosity to psychosis. But she becomes, she starts becoming convinced that she's got to take this child's life to save the world. And if she doesn't, this child will become, maybe the Antichrist or something, and take over the world. So this sounds bizarre to everyone out there, I'm sure. But this is real stuff. I mean, this stuff really happens. And the reason I bring this case up is because in the media, occasionally, there are these tragedies that we read about and hear about, where a woman will do that. She will take the life of her newborn child or her infant, okay? And we all stand back aghast and go, how could you do something like that, okay? We can't relate to something like that because we haven't been psychotic, okay? When I say psychotic, remember I said this is something that the person believes is absolutely true. And it's also something that is very stuck on their minds. They can't get it off their mind. It's a broken record all the time. All they think about is this child is possessed by the devil. I've got to kill it or it's going to take over the world. That is, that sounds weird to the rest of us, but that thought can cause a person to do something like this. So in this case, we're talking about a person who not only had, I want to make sure you understand that not every case of postpartum depression has psychosis with it. Okay? I just use this as an example because I wanted to discuss some of the stuff that you see in the media sometimes. But not every case does. You remember the whole thing with, was it Brooke Shields, I think, and Tom Cruise, right? And they were going back, they were kind of bantering back and forth. Brooke Shields had suffered from postpartum depression. To my knowledge, it wasn't any psychotic depression. It was just postpartum depression. But she took treatment for it, and Tom Cruise kind of criticized her for that. So she was an example of somebody who had postpartum depression without any psychosis. In most cases, it's more rare to have the psychosis, but I just wanted to make sure you realize that it is possible, and this is what sometimes happens in some of these cases that you see in the media. Well, what is postpartum depression? It's a depressive episode with a lot of the same symptoms that we talked about earlier for depression, depressed mood and all that, and it has to occur within 4 weeks of delivering a baby. It occurs in about 1 in 500 to 1 in 1,000 deliveries. And it may be more common in new mothers. Remember this case, this was the first baby that she delivered. Again, the symptoms can be the same basically they are the same as a major depressive episode. So it's all the same, the guilt, the worthlessness, the changes in energy, sleep, appetite, all these things, and sometimes even suicidal thoughts. if the person does get psychotic with it, what you see a lot of times is that it involves the baby in some way. So like in this case, for instance, that the mother becomes convinced that the baby is possessed by the devil. Another thing that can happen is sometimes the mother will be convinced that the baby has special powers of some type. So the obsessions, this feeling like there's something wrong with this baby, or there's some possession or something like that. That's what can end up in the mother taking the baby's life. Now you might be wondering, you might be thinking about baby blues. I mean, have you ever heard of baby blues? People, what is the difference between postpartum depression and baby blues? And you might be wondering that. Well, baby blues is something that lasts about 3 to 7 days. It can be tearfulness and some of the same symptoms. Usually doesn't interfere with function as bad, and is not as severe, of course. Okay, but it's more common. It's more common than full-blown postpartum depression. The other risk, I guess, the other big thing, even if a woman doesn't get psychotic with the postpartum depression, the other problem is that, as you know, when you first deliver a baby, bonding is kind of a big deal for that infant, for development, right? So if the mom is very depressed and doesn't want anything to do with the child, and is very negative about everything, and really is so caught up in her own depression that she can't focus on the child, that's going to interfere with raising that child. And if there's nobody else to step in, that whole bonding process may not occur, and that's a problem for child development. So you definitely want to take this seriously and treat it, or bring your loved one to treatment if you notice this occurring, and also step in and try to help out with the baby, because that's kind of important. Sleep is an issue. We sort of talked about that. A lot of times these mothers, they feel extremely guilty because they know, on some level they know that they're supposed to be taking care of this infant. And they feel so guilty that they're not, and they don't feel like it. And they feel like there's something wrong with me. I can't, so they feel ashamed, I guess. They may not even talk to anyone about this. So it may be something you have to kind of observe, because they may be too ashamed to say anything about it. The thing to keep in mind, too, is that once a woman, like let's say she's had one baby and she gets postpartum depression, with the next delivery, that's another high-risk period. In general, what I tend to think of is that whenever a woman has an episode of depression or any psychiatric illness that we think is related hormonally somehow to some dramatic change in her hormone level, that really you need to be aware of, you need to be alert for any kind of recurrence of that type of psychiatric illness anytime there's any huge hormone change. So if a woman has postpartum depression, for instance, you got to watch for premenstrual dysphoric stuff, premenstrual depression. Okay, you also need to watch for depression if they were to have a hysterectomy or go through menopause. So any kind of menopause may not be so bad because it's the hormones at that point sort of sputter. They kind of sputter and do this kind of thing and go down over time. Whereas with a hysterectomy, it's boom. And with child delivery, it's the same thing. It's a dramatic change. So you got to be aware. And there are some doctors who, if a woman has an episode of postpartum depression, and then gets through that, and then has another pregnancy and gets ready to deliver, a lot of times the pregnancy itself is protective against the depression, which is kind of interesting. Probably again hormonal. But as soon as she delivers, a lot of times the doctors then will start a medicine, whatever it was that helped her before, start that back again immediately to get it in her system and going right away, so that hopefully she doesn't have the same issue. Some doctors, and it's a risk-benefit thing, but some doctors will even start it at the third trimester, start the medicine, treat the third trimester all the way through the delivery to get them through that, to get the woman through that risk period. Because as you may know, the antidepressant medicines take a while to work. They take, like I said, 4 to 6 weeks. If you start it right after she delivers, 4 to 6 weeks is a long time for that to kick in, and she may get pretty depressed in between. Now, anytime you use medicine in pregnancy, there's some risk involved in that. Okay, so some people think the risk is higher when the brain is developing in the first trimester. Maybe, okay, and I don't know that you can say that there's no risk for sure in a third trimester. So anytime there's a decision about treating a woman with medication while she's pregnant or while she's breastfeeding. Those are risks. You have to really weigh the pros and cons of that before you do it. So, and same thing with the breastfeeding, like I mentioned. A lot of the medicines will go through the breast milk into the baby, and you might want to. The doctors a lot of times will advise the woman to bottle feed. And again, it gets into a risk-benefit. You know, how much advantage do you get from the breastfeeding versus the disadvantage of if you don't treat the woman and she gets depressed. You know, what's better or worse for the baby? Those are tough decisions. You know, I've been there. Those are kind of hard decisions. Typically, this is something medications is required for. Psychotherapy can help, and I always recommend psychotherapy, certainly to help with the bonding of the infant and with some of the stress that's involved in becoming a new mother. But the medications usually are necessary for that. So the outcome, what's the outcome of this case? Psychiatry was consulted when the patient was still in the hospital, and because the OB/GYN physician recognized that the patient was getting postpartum depression and was really concerned about it. The patient was treated immediately with an antidepressant and an antipsychotic medication and psychotherapy to help her bond with her infant once the psychosis cleared. She improved in her mood and psychosis and remained on the antidepressant and did okay. So that's postpartum depression. There was some interest in postpartum depression. If there's any questions about postpartum depression. Yeah?
Prior to, if the mother has experienced depression teenage years,
okay,
menstrual cycles coming, got that 13, 14, 15-year-old, she ends up pregnant. She's on her antidepressants when she's 3 months along, okay, because she's had all this trouble here. Isn't that a form of postpartum? The doctor keeps her on her antidepressants because of all the age level, maturity level, what this young teenage mom's going through. Boom, we have big hormonal change to give birth to a baby.
Yeah.
So they weigh the risk of that young mom that's facing all these things, keep her on her medication, because I've worked with several teens that are currently on Prozac, currently on different medicines. They did not take them off during pregnancy.
Yes, I mean, sometimes you definitely leave a person, a woman on.
I thought you were saying they would prefer to take them off.
You're talking about a little different situation. So you're talking, I think, now correct me if I'm wrong, you're talking about a young girl who is treated with an antidepressant for depression,
right,
before any pregnancies or anything.
Yes.
So she's had depression independent of the hormonal stuff, right?
Right.
So this is a little different because she could become depressed at any time. We can't really trace it to hormone change.
Okay,
so
a mother that's 25, 28, still same scenario. So the age barriers are no different. Mom's been on, she's had some problems, she ends up pregnant. They take her off that depressant?
Some doctors will take a person off, take the woman off of the antidepressant, but I guess the key is that hopefully you have a doctor that's seen you for a while and has seen you through the depressions. And if you've seen somebody through a depression and it's been a pretty severe depression, yeah, I mean it's all risk and benefit. So what you do is you talk to the person, you say, look, Sally, or I always keep using Sally, I don't know why, but Sally, as your physician, I got to tell you that you've had 2 episodes of depression before, and they were both pretty serious episodes of depression. And we've decided to keep you on medicine all this time. Now you're pregnant, and the medicine can affect it, could affect the baby. We think that it's fairly safe, but sometimes you don't know these things. You can't say something's 100% safe. So we have to weigh the risk of taking you off the medicine to protect the baby, and then you getting very depressed again. And sometimes, incidentally, one thing I haven't discussed in this talk, but I did before in depression, is the more times you get depressed, the more episodes you have, the worse each one is. So that you really, she's had 2 already, the 3rd one may be a humdinger. So do you want her to get depressed while she's pregnant? You have to have that discussion with her and with, if she's a minor, with her mother, and you all sort of make it as a team decision. And but it's a little different than postpartum depression, because you see how it's different, because she had depression already.
So there was the existing
depression, and
take her off of it. We deliver baby. we go right back on our medication because she's in full postpartum.
Yeah, that's one option. And actually, there's no textbook for
Can
this.
last up to 2 years after birth of the baby, is that correct?
Can the depression last for up to 2 years? Yes. I mean, an untreated depression can last, any depressive episode that's untreated can last up to 2 years on average without any treatment, which is why you want to treat it.
So mom gives birth to baby,
Yeah.
medicated for postpartum, goes into the full case there. Okay. Can get pregnant 6 months later, give birth again, go back into postpartum.
Yes. Yeah, postpartum, once you've had one episode of postpartum, it's kind of likely you're going to have another one. Not 100%, but it's pretty high. So, these are details. I guess these are tough things to, you have to decide these things on a case-by-case basis. That's the hard part. Because you have to consider all the risks and benefits of each individual case, and no two cases are exactly the same. So that's what's hard about it. In general, if they've had a very severe depression and it's independent of the hormonal, it's not a postpartum depression, it's independent. You need to think real hard about whether you keep them on antidepressants during pregnancy or not. And that's a risk. We used to say that the newer antidepressants are very safe, and now there's some brand new data that just came out with Paxil showing that there may be some issues there. So, it's hard to know with the studies and the way they do these things. Believe me, I know firsthand now after being a clinician on the one side and then going into the pharmaceutical companies. You see both sides of it. When you're a physician, you criticize the pharmaceutical company. When you're a pharmaceutical company person, now you see sort of what they're up against. It's difficult. A lot of ethical things. You can't. We certainly couldn't do a study where we signed up a bunch of pregnant women and said, here, we want to expose you to this medicine and see what happens to your baby. You can't do that, right? So all you have to go on is sort of accidental exposures. Women who have been exposed, now what happens? And that's really not the best way to collect data. You don't collect very good information when you do that. So, does that answer your question okay, all those? Okay. Any other questions? Not a lot of time left, but let's talk real quick about premenstrual dysphoric disorder. Case example, this is a young female who has who has normal mood and functions well a few weeks a month. But about a week before having her menstrual period each month, she starts to feel poorly about herself, has low self-esteem, becomes anxious, is moody, gets angry quickly, loses interest in work, which she normally enjoys, can't concentrate, has pretty low energy level, she craves sweets, has bloating and breast tenderness. These symptoms cause her to miss work a few days a month, and she's at risk of losing her job. But the symptoms always lift a few days after starting her period. So this is not a classic major depressive episode that starts, gradually gets worse, and keeps going until you treat it. This is something that is a weekish. It could be a little longer, a little shorter before the menstrual period, and then once the menstrual period occurs, it lifts. Again, think about it for a second. That has to be hormonal, right? It has to have something to do with the female hormones and the fluctuations therein. So really, that's the definition. That's how you define it. That's how you know what it is, because it meets these criteria I'll talk about in a second for a depressed episode, but it occurs only these times, and it lifts right with the menstrual period. The symptoms are pretty much the same as a depressive episode. Some of the things that are a little different, I suppose. Well, not so different, I guess, but the feeling bad about oneself. I mean, that happens with depression anyway. So that's one. Sudden mood changes. Sometimes the person's mood will, they'll be very irritable one minute, and they'll be depressed the next minute. Maybe feel okay for a little while. Anger and irritability problems with relationships. Again, these can occur with everyday ordinary depression too. Lack of interest, trouble concentrating, feeling overwhelmed or out of control. That's another one. And then physical symptoms that occur, like headache, breast tenderness, joint pain, bloating, and things like that. Now, you might wonder, is this PMS? What's the difference between PMS and premenstrual dysphoric disorder? PMS is again, it's sort of like the baby blues kind of. When you compare that to postpartum depression, it's the same kind of thing as comparing to PMS to premenstrual dysphoric disorder. But basically, it's not as severe. You can have a lot of the same symptoms, and they don't typically interfere with function as badly as premenstrual dysphoric disorder does. Women who, remember I said that women who have difficulty with sudden hormonal changes are at risk for, like, so for instance, I guess let me just get straight to the point. A woman who has this PMDD is at higher risk to have a postpartum depressive episode. So let's put it that way. And also, for like if a hysterectomy occurs or something like that, those are high-risk periods. It's estimated to occur in about 3 to 5% of women. Usually starts in the teens to late 20s, and then it usually seems to worsen with age and then cease with menopause. So it goes away with menopause, which shouldn't surprise anyone because the hormones at that point are sputtering out. You have to make sure, before you go diagnosing this, you have to make sure that it's not related to something else, that it's not a full-blown depression, or it's not a bipolar disorder, or some anxiety disorder, personality problem, something like that. Because those things would all be treated differently, and you don't want to use an antidepressant necessarily right off the bat in a person with bipolar disorder, because you might make them worse. The outcome in this case, I'll read this outcome to you. The patient's family doctor recognizes this as more than just PMS, premenstrual syndrome, and diagnoses premenstrual dysphoric disorder. There's a lot of acronyms and different big words in this talk. Now that I have to give the talk, I kind of realize that. So after discussion with the patient and also charting of her monthly menstrual cycle and mood changes, which also is very important, by the way. Because how do you know? I mean, you kind of have to know concretely if this starts with a week before the period and ends with the period, or right after that. I mean, because if there are other episodes of depression and stuff in between, then it's probably not this disorder. So you got to chart stuff. The physician then recommends an antidepressant starting a week before the symptoms usually begin and stopping with the period. So really, in some cases, you can get by with using an antidepressant 2 weeks a month. And then you stop it. The symptoms improve 75% over what they were, which allows her to save her job and increases her function and quality of life. So in this case, the treatment helped her. Now, I gave you all positive cases here, so you're probably thinking, yeah, right, doc. Like I'm sure everybody gets better and that kind of thing. But and of course, not everybody gets better. I would say everybody gets better eventually, but not on the first swing like that. So, but those were examples. Questions? Does anybody have any questions about it, really any of this stuff or any other topic? That's pretty much the end at this point.
I noticed when this first came to my attention, it was through a friend who said she was going through it, and her doctor had given her that type of dosing.
This is the premenstrual dysphoric disorder.
Yeah, the PMDD, and her OB had said, take this a week prior and continue through this cycle, and so it was the 2 week. And then after about several months, they changed it to now just take it continuously for a month. And so now that seems to be what at least our doctors are doing. Is they're giving it, it's usually Seraphin is their choice.
Yeah.
Or Zoloft, I believe, is another one they use in there. And then now they're just saying, just take it every day, daily.
Yeah.
And so I don't know if that's just our doctors doing it that way, or
no. I think
it's a common.
A couple of issues with the every 2 week thing. Okay. One issue with every 2 weeks is that you have to remember. It may be easier if you get in a routine of taking something every single day. Okay. If you do it you just do it 2 weeks out of the month, then you're not in a routine, or it's harder to be in a routine. So sometimes folks forget to take it. Another issue is that some of the medicines are kind of short acting, so when you start and stop all of a sudden, especially when you stop, you get some withdrawal symptoms and things which are uncomfortable and patients don't like. Seraphin doesn't have that issue because it's longer acting. Zoloft too, you can have some withdrawal, but I would think after 2 weeks, and since it does have a little longer activity in the body, you probably wouldn't have as much trouble with withdrawal. But another thing that can happen is that you try the 2 weeks, and for whatever reason, any of those reasons, it doesn't work out for you, and then they say just take it all month long, And sometimes doctors, just for ease in their minds of trying to remember when are they on it, when are they not on it, they would prescribe it, and the person takes it every day.
So during the period of time where they're not suffering with the PMDD symptoms, it's still okay to be on an antidepressant. It's not going to affect them.
Oh, is it going to hurt?
Or is it going to affect them in any other way? Or
It shouldn't. If you give somebody an antidepressant who doesn't have depression, outside of the side effects, you might have side effects like anybody that takes any medicine. Really, you can have side effects from it, but it doesn't. It wouldn't. If your chemicals, I suppose, if you want to think of it that way, the chemical imbalance theory and all this, if they're already, I don't want to say normal. Yeah, I guess functioning as best that they can, or to their optimum for you as an individual, you're probably not going to notice. Like, it's not like somebody's going to. I think there was a myth out there that folks that took Prozac, they'd get happy no matter how they felt. I mean, if they're already happy to start with, they're probably not going to feel much happier. So it isn't going to hurt outside of the side effects, probably, to take it during those 2 weeks. I mean, really, the advantage, I think a lot of people are just they don't like taking medicine, So if you can tell somebody, look, you can take this for 2 weeks, and then you're off. Sometimes psychologically that people like that a little better. And that's okay. I mean, I think as long as it works, I think it's worth trying it. And if it doesn't work so well, then you go to then you take it all month long. So does that answer your question? Okay. Yeah.
Well, how about, since you say it takes so long for an antidepressant to take effect?
Yes.
How does it work if you just take 2 weeks and then
$64,000 question, isn't it? That's a great question. And let me repeat it. The question is, we have a smart audience member out here, but the question is, yeah, Doc, you said these things take 6 to 8 weeks to work. Well, how the heck are they going to work in 2 weeks? And then you stop, and then you start. 2 weeks later, you start it again. How's it going to work? The answer is I don't think we know how that happens. But it's been studied, and it does help. So these medicines, they work on the chemicals in the brain, okay? And we know that. When they do that, like, let's talk about the newer ones. Let's talk about serotonin medicines, okay? Serotonin is one of the chemicals in the brain. When you take a medicine like Zoloft or some of these others you talked about, Serafim, the serotonin gets boosted within 3 days, okay? Why does it take 6 to 12 weeks for effect, right? Because it's not just increasing the serotonin, I don't think, anyway, in my mind, and most of the other docs, scientists' minds. It isn't just increasing the serotonin that treats it. It's probably that, which then kicks in something else. It's a cascade of events that has to occur, which is why it takes that long to work. What's different about that with PMDD? I don't know. It's certainly hormonal, right? So is there some effect directly of serotonin on the hormonal system? Is it somehow regulating that system in some way? It could be. It could be. I don't know the answer.
So if it works, maybe it is confirming the diagnosis that PMDD.
Yeah, if it works, I would say if it works for those 2 weeks, and then you stop it, and it for the other 2 weeks, and the person is doing just fine, it's pretty likely that's really what it was, is PMDD. If you try it and it doesn't work out, it maybe it's more like a major depression that just gets worse premenstrually. Because I have had a lot of folks like that. They have depressive episodes, and they just get really, really worse premenstrually. Then when you treat them, their depressive episodes, they get a lot better, but they still tell me if they had to judge, they get worse. They're worse premenstrually than they are any other time of the month. So, yeah, I think that's just, unfortunately, that's one of the disadvantages of estrogen and progesterone, I think. But I don't know. Any other questions? Yeah.
What do you do before prescribing any kind of medication? Do you do any kind of, when you talk to or depressive people, prior to that diagnosis of Medicaid, what's some of the things you can do?
So you're asking if somebody comes to see me, and you're saying they have depression, or?
Yeah, they think they're not sure what they've got. The family member brings them.
Family member brings somebody in, and to see me, and so you're asking me how do I go about diagnosing?
Yeah, how is there try these other things prior to medication, or is it always just going to be?
No, it's not always medication.
So what's some of the other things that you would do, that they could do to help themselves?
Oh, okay. So some of the things that folks can do to help themselves. Let me just, I'll tell you how I approach this, okay? And realize I'm one physician. You know, I don't have all the answers. And other physicians out there watching this thing are probably going to, you know, oh, I don't agree with them on this or that or the other.
That's saying, oh, so depressed,
Yeah.
it's a gloomy day,
Yeah.
I this great day. You're going, okay, is that this? Is it that?
Yeah.
Everything in the world's negative.
Yeah.
Yeah, and it's just like, okay, I know what I do to get out of that. What do you do to help someone else?
Right. There are a lot of things you can do to treat depression that are not medicine related, okay? And there's actually some data on this stuff. There's some studies on this stuff. You know, exercise, aerobic exercise is one. Cognitive behavioral therapy is another. That's a type of therapy where, you know, if you think about it, a lot of us that have these negative thoughts, we call these things, you know, cognitive behavioral therapists call them automatic negative thoughts, okay? These are things like, boy, I'm just really no good. Everybody sees it. You know, they all know it. I know it. I'm no good. I can't do anything right. You know, and so you know, it may not, you don't say it out loud, but you think these things. These are automatic negative thoughts. They occur a lot when you're depressed, okay? Sometimes they occur even when you're not depressed, and you can make yourself depressed by having all these things, right? Some of these things occur because you were raised in a way that sent you that message. You were always raised that you were not good enough. You know, you were put down all the time. You're fat and ugly. Get out of here. You know, I'm sick of seeing your face. That kind of stuff. And believe me, it shocks me too. There are parents there are people who do treat their kids this way. Okay, you guys know that. Right now they're shaking their heads. Anybody that's had any dealings with mental illness and treating folks with these things knows that this is what happens in a lot of cases. Well, you can't be told that your whole life growing up. You know, especially during the years that you're forming the opinion about yourself, and you can't be expected then to grow up and have this wonderful self-esteem and walk around thinking you're all that in a bag of chips, right? It's not going to happen. You're going to walk around thinking all these automatic negative thoughts about how crappy you are, okay? One of the ways you can help with that is to really start challenging the person on those thoughts, okay? And that's what cognitive behavioral therapy does. Basically, and it sounds goofy, but you send the person home and you tell them, here's a mood chart, here's a thought record, And a thought record is where the person, first thing they usually notice is they feel bad. That's all. So you tell them, okay, next time you feel bad, I want you to think back now, what thought did you have right before you had that bad feeling? Well, I thought, so they take it home, they decide that they were depressed, okay? Well, the thought that they had right before that was, I'm no good. And then you have them actually weigh the evidence, for and against the fact that they're no good, okay? So you have them do little things in your office like, what would your friends say? What would your wife say? What would your kids say? What would your boss say? What do you think everybody else would say, And then what's the evidence that you are worthless? They may say, well, Dad told me that all the time growing up. And that's it. So you show them that, okay, so all these people think you're not worthless, and your dad said you were, and you're going to think he's got all the answers? What's up with that? So you start challenging them to think like this, to challenge how they think about the world and things. That can help lift depression. Believe it or not, in study after study after study, that's been shown to help with depression, but not only depression, anxiety, schizophrenia. It's been helpful for a lot of different psychiatric problems. So that's one kind of psychotherapy. There's a whole bunch of different kinds of psychotherapy. The one thing I would say is, you sort of alluded to the question of how do you know when to use medicine versus psychotherapy alone. I would always start with psychotherapy unless there are some things that are, and I guess the short answer to that is it's through experience. I've got enough experience now that I can sit with somebody, take a good history, and figure out, do I have the luxury of time to wait for the psychotherapy to work, number one? Can the person focus well enough to do the psychotherapy? If they're so depressed that they can't concentrate, memory is shot, how are they going to be able to challenge their thoughts and stick with me in sessions and things like that? Those folks, if they're psychotic and they can't, all they can think about is that they're condemned to die because they sinned, you can talk about challenging that thought. It's not going to happen, okay? Those folks need medicine. And really, if you don't use medicine pretty quick, they're going to end up in the hospital. So I guess I take the history and I sit with the patient and the family and I kind of figure out how bad is this? Is it pretty darn severe? And if it is, we got to do medications to start with, or treat, ECT or something, some other type of medical treatment. And certainly, as soon as we can, we'll get the psychotherapy going. But they got to be able to focus and stay with us and things like that. So, does that answer the question?
Yeah.
Okay. That's a good question. And we haven't really, I guess I'm a little remiss because I should have talked about that in other sessions, a little bit about what a psychiatrist, maybe that should be some talk sometime, what a psychiatrist really does. I think a lot of people think I'm like a head shrinker, they either come into my office, I'm going to I don't know, read their minds or something like that. It's really not like that at all. It's just like any other physician, only I don't do a lot of laying on of hands. I don't do a lot of stethoscoping and reflex checking and all that stuff. It's if I have to, I will, but mostly it's sit down and talk to me about how things are going, and take a good history about your medical history, psychiatric history, and then all these symptoms. I have to unfortunately put the person going through all these symptoms that I put you guys through, and screen them. Basically, it's called a psychiatric review of systems. It's a way of asking a lot of different questions to rule out. So, I do childhood history, drug and alcohol history. You do a mental status exam. It takes a while. It takes me a long time. It takes me about an hour and a half usually to get through something like that with a person. So it's, but that's time well invested, because then they learn about you and that they can trust you, but also you get a better idea what you're dealing with, and you're better able to treat them in an appropriate way. Sometimes you don't spend enough time with a person, you don't really know what you're treating, and then you try something just as a stab in the dark and it doesn't work, and that's not really ideal. So, other questions?